welcome everyone. We're excited to have everyone here tonight. This is not an April Fool's joke. We are doing a webinar on April 1st. So I'm excited to be here with some of our fellow colleagues. We haven't had them on before, and it is a very, what I'm going to say, collaborative effort. And Dr. Wilkerson, you are my fierce leader here with us tonight. I'd like you to say hi to everyone as we're bringing everybody in here. It takes few minutes welcoming everyone. Drop where you're coming from. We love to see what state you're in. Of course, Dr. Wilkerson and I are in sunny, warm Florida right now.
Right, which is beginning to spread. The last time we were on this call 2 months ago, we were asking everybody what the temperature was where they were, and we were getting reports of 7 degrees and 14 degrees. And so I'm assuming it's all in the 60s and 70s and 80s now. But we are so excited to have our two guests. Of course, Patti has worked very closely with us. Even when we started IDM Scholar Society, Patti was part of our main team until she decided she wanted to play a little more golf and hang out with Dr. Wright more than with us, which I can't blame her. But Dr. Wright has not been with us before, but we're so excited, David, to have you share with us just the wealth of information and great ideas that you've initiated together with Patti. And so thank you for taking the time tonight to be with us.
And for those who don't know, Patty and I go way back. Yes, my whole professional career of 30 years. I'm going to age both of us here, Patty, a little bit. But back in 1995, that was the hygienist working next to me over there in that other square. And so we have a lot of history together. And just to come full circle to be in this collaborative network really says a lot. And I'm just from the bottom of my heart, love you to death. And so glad that you are back on here with us. And I know you attend many times, but we're going to drop the bios in there because we do want to get started. But please go read those. Having you here, Dr. Wright, as well, is an honor. And I'm just so really proud of what you've created. Back in 2023, you launched Renew Health for the very problem I'm going to say that many of our dental colleagues still think that they're suffering from. So I think you're going to kind of close that gap and close that pain point tonight because we're really looking for what I call like telemedicine, this asynchronized healthcare that so many of our patients need and don't even know that's available. So I'm going to turn it over to you two rock stars as you guys have been working together, really bringing our whole dental and medical worlds and showing us how we can collaborate here in our community, but even taking that out to our other colleagues. So, Dr. Wright and Patty, take off. Let's
Hmm.
hear.
Thanks,
Thank,
guys.
thank you, Laura. Thank you, Whit. We've been looking forward to working with you all because, as the title slide suggests, there is a medical problem that does have a dental solution. We have to have our dental colleagues collaborative with us to do everything that we're trying to do with our patients. By way of disclosures, Patti and I, as you know, helped to start and are working with and for Renew Health. I'm both a co-founder and CMO, and I still see patients every single day.
Are
And
you
Pat,
sharing? Are you sharing your screen?
Yes,
can you see my screen?
I can.
Oh, okay. Sorry, it must be me.
And Patti is our dental liaison. So she's not chairside anymore, but she actually plays a more critical role, and she'll talk about that during her part of the presentation. Tonight, we want to discuss several things of this role between the dental team and the medical team. Renew Health was started to halt and stabilize and reverse all sorts of diseases, arterial disease, diabetes, the journey towards dementia, stroke. I could go on and on. About half of all cancers are related to what we're treating. And so we're going to talk about specifically how atherosclerosis even happens and what's the dental role in allowing plaque in the arteries to affect all of our patients, cause death and disability. We have to have our dental team to heal arteries. And it really is beautiful when we work collaboratively. So please, I hope this opens your eyes to what's possible. Don't be limited by the now, but look towards what's possible. This is an ironic real billboard outside of Bowling Green, Kentucky. You'll see I took that from one of the Bale-Deneen method slide decks, but this is real. And yes, gum disease can kill more than a smile, but it's ironic that they have a tobacco advertisement right beside it. So everything on those billboards is killing people. Doctors Bale and Doneen, who are two of my mentors, and Dave Vigoroost, published this article, which is in our references, almost a decade ago now. And notice that they identified that you all have a substantial opportunity to reduce the number one cause of death and disability, and that's cardiovascular disease. And at the time, their paper was looking at just periodontal disease and high-risk pathogens, but as you'll learn today, it's expanded to even beyond that. So we need your help restoring arteries and saving lives. When I do in-person presentations, this is an audience participation sort of question, so this is more rhetorical right now, but most people don't know what the first symptom of heart disease is, and it actually is either their heart attack or their death. Half of all people, that's the presenting problem. Oh my goodness. In Memphis, Tennessee, where I'm at, 3 people per day, statistically, 3 people per day die suddenly from cardiovascular disease. Half of them, that was their first symptom. So this is, and let me fold in that doctors are trained, physicians are trained to ask about symptoms. And if symptoms are absent, then we stop looking for whatever the disease is. Heart disease is no different. If they don't have chest pain and shortness of breath and a variety of things, then it's off the chart in terms of, are we worried about it? Well, this disease of cardiovascular disease is a lot like the Titanic. Most people think they're unsinkable. The Titanic thought it was unsinkable. And yet the night that it sank, it got at least 5 warnings to change course. At least 5. All of them were ignored, as we know, and disaster happened. And before the disaster, they sent out an SOS signal, save our ship. Well, in this modern day, the equivalent of 3 jumbo jets, 500 passengers each, are plunged to their death because of cardiovascular disease. Has anybody heard the news announce the crash of that 500-person jumbo jet every 8 hours? No. It's invisible to most people. It's taken for granted that this is how people die. Well, we have our own SOS. Instead of save our ship, it stands for stop oxidative stress. And you're going to learn what that phrase means and how we apply that. From the perspective of aging and declining health, the fact that's on the screen now is tragically real. And think about this. The average person is dying at age 78, which means from age 65, when they hit, quote, retirement age, to 78, the average person is in declining health. And in fact, the statistics show that the average 65-year-old will have 1 healthy birthday after age 65. Well, this candle is a metaphor for how oxygen combined with inflammation with this flame consumes the candle. And in the body, oxidation consumes cells and functional organs and results in these, quote, diseases of aging. The neat thing is you all see patients more often than their primary care doctor does for the most part. You're seeing them twice a year. They get more preventive care already in your office by what you're doing for their teeth. And you get to see them twice a year, and you're already talking about sugared drinks and tobacco and dental hygiene. You're doing lots of great things already, but there's more that you can be doing. Because now you can tell your folks they're not just saving their teeth and their smiles, they're saving their heart, they're saving their brain. They're either controlling their diabetes better or, more importantly, preventing diabetes from happening. So coming back to what are the symptoms of a heart attack, which is their death or their heart attack? Well, what causes that heart attack? What causes that stroke? And it's this thing called inflammation. Inflammation is the body's attempt to heal injury, to heal damage, to fight off a threat. And that's great if it's a splinter under your finger or if it's a strep throat. But if it's chronic inflammation, whether it's of gum tissue or arterial tissue, that's a problem. And speaking of periodontal disease, it's the same answer. It's inflammation. You all know that some of your patients have much more aggressive periodontal disease, and most of that's attributed to the host response. Not all of it is, but a whole lot of it is. And so it's, yes, bacteria are needed, but then there is this host response. Well, Amy Doneen, again, one of my mentors, says this to almost every audience she talks to, that just because plaque in the arteries is insanely common doesn't mean that it's normal, and certainly doesn't mean that it's harmless. Well, I'll say the same thing about periodontal inflammation. Just because you see it all the time in your chair, and that little bit of bleeding that you saw, is that really normal? Just because you see it all the time doesn't mean it's normal and doesn't mean that it's harmless. And importantly, even a normal appearing mouth can harbor the pathogens that we're going to talk about today. So please don't let your eyes fool you. Go into that visit armed with the knowledge that, guess what, just because their mouth looks normal doesn't mean they're safe from their arterial disease. I want to just briefly talk about something that Patti will come back to in her part of the presentation, but one of our workhorse tools in finding arterial disease is a very simple test using an ultrasound beam, so there's no risk. It's not painful. It takes 10 minutes. But it's different from any ultrasound our patients have ever had, because instead of just looking at blood flow, it's actually looking at the arterial wall. And I'll tie that into another slide, because it's the arterial wall that's damaged and diseased and the source of heart attack and stroke risk. So we can look in the arteries, see, is plaque lurking? We can even tell how quickly their arteries are aging, which is a window into how long has their body been under assault and how have their arteries responded to that. Plaque anywhere carries a 40% 10-year risk of either dying or being hospitalized because of a heart attack or stroke. Let me say that again, a 40% 10-year risk of death or hospitalization from a plaque rupture problem. There's no such thing as just a little plaque. And on this study, I've highlighted the fact that we can measure how thick the plaque is, and more importantly, the type of plaque. And you'll learn more about this as I go on, but the younger the plaque, the more cholesterol's in it, and the more inflammatory it is. When cholesterol gets trapped, it's highly inflammatory because those inflammation cells are trying to heal this. And to a certain extent, they are creating healing over decades, but that inflammation is what leads to plaque rupture. As plaque starts to heal, it goes through different phases, and we can actually see if somebody's plaque has fully healed. And that's one of the endpoints of our therapy. We can see how people are aging from the outside, but even looks can be deceiving. We all know people that look younger than their years and people that look older than their years. And the same is true for their arteries. that they can have normal blood pressure and normal cholesterol and normal lots of things and still have aging arteries. So let me go back to this concept of why does this happen? It's really a cellular problem. Cells are designed to function in a very specific way, but they are prone to becoming damaged and affected by something called oxidation. Some of you may have read about free radicals. That's the same thing. So free radicals are the actual chemistry of oxidation. But oxidation damages cells and arteries. Let me say that again, cells and arteries. Brain cells, heart cells, kidney cells, and oh yes, the arteries that go there. And this oxidation is an actual poison that's causing the damage. And there's about 30 identifiable reasons for patients overproducing oxidation, and that oxidation therefore damaging them and leading to all of these downstream effects. You can see that if we identify oxidation, then we can halt this progression, and that's the magic. Briefly, I want to show you what actually happens in an artery to cause plaque to grow. In a normal artery, cholesterol, which is a waxy, oily substance, is carried inside of what I like to call a suitcase that allows it to dissolve and travel in the bloodstream. This suitcase is something called ApoB. Well, that suitcase is supposed to carry cholesterol from the liver, where it's manufactured, to every cell in the body. Well, it gets to those cells by going right through the arterial wall. It goes into that inner lining of endothelial cells. They take out the cholesterol they need. Then the ApoB goes to the next set of cells and all the way through the artery. And regardless of how high your cholesterol is, it's supposed to go seamlessly through the arterial wall until oxidation strikes. And now it makes that middle layer of cells, which for those of you that are science nerds, it's a vascular smooth muscle cell layer, that middle layer. And those cells actually start being transformed and start creating a sticky substance that traps cholesterol. And I think my screen stopped sharing the right thing. Let me try to get the correct screen back in front of you all. I think that's right. Laura, is that good?
Yep. You're
Yep.
back.
So ApoB suddenly gets trapped, and it gets trapped right under that endothelial lining and starts to accumulate. Well, now this ApoB that's full of cholesterol also gets oxidized. Now the cholesterol is also toxic. And now we create inflammation. Inflammation then damages neighboring cells, the lining of the artery, and we're off to the races. And that takes decades, and it's happening silently. And that artery channel is wide open. There's no blood flow problem. The problem is underneath the roadway. And I tell my patients, think of your arteries as a highway carrying goods and services everywhere that they're needed. But just like the highways in Memphis, Tennessee, and probably in your city, potholes are everywhere. And plaque are discrete, quote, potholes in the artery that are these collections of cholesterol that is inflamed. That's a landmine waiting to grow and cause problems. Well, if we just ignore it, if we just watch it, the natural history is over the next decade or so, it's going to start growing. And at some point, it's thick enough to call it plaque. Honestly, that's an arbitrary term because guess what? That number of how thick does it need to be called plaque is basically 2 times the normal thickness of that part of the artery. In other words, we are waiting 2 or 3 decades before we even call it plaque. Well, all of prevention works best in the sooner we get to people. So I call those earlier stages pre-plaque. It's plaque in the making. And that pre-plaque and that early plaque is the most inflammatory. It's the most dangerous. And if we don't do anything about it, that little tiny volcano of toxic stuff will tear through the inner lining of the artery. And that plaque rupture then instantly causes a scab or clot to grow to plug up the hole. Sudden catastrophic event. If it's in the heart, it's a heart attack. In the brain, it's a stroke. I'll tell you what, though, most plaque rupture happens at this stage where the artery is almost completely wide open. That plaque still ruptures. It doesn't shut down the artery, but it now has a fresh scab and blood flowing over it. And in the dental world, the last thing you want is that fresh clot in a extracted tooth socket to fall out. Well, that friability in a dental socket is exactly what happens in the artery. And we get microemboli, microclot that travels downstream to the capillaries. And now we get a nest of cells in the brain or the heart or the kidney or the wherever that dies, and you don't feel it. So preventing catastrophic plaque rupture and silent plaque rupture is our goal and is a reality. This is what an autopsy of somebody's artery that had plaque rupture looks like. And this ugly chocolate-covered blackberry is a clot. And you can see holes in the lining of the artery. And this person died because that clot actually did fill up the entire artery. Notice this stained part over here. Well, that was plaque rupture that happened years ago that was silent. The staining is from the iron in the blood, in the clot that was there. So the arteries are very dynamic. The plaque life is very dynamic. It's growing, it's getting inflamed, it's rupturing, it's partially healing, it's growing. That's a recurring theme. So identifying oxidative stress is critical because that triggers inflammation, and the fruit on this tree is an artery getting. The dental team can influence all of these boxes. Oh my goodness. It's not just periodontal disease. It's endodontic. It's sleep. And oh, by the way, because those things create oxidative stress, they contribute to high blood pressure and cholesterol issues and insulin issues. And when you mess up the oral biome, you often mess up the gut biome. All of these things are interrelated. Now, I hope you can see why we rely on our dental team to be a part of this solution. So let's talk about the dental world. And I'm clearly not a dentist, so I'm not going to teach you anything about periodontal disease and management that you probably don't already know, but I want to make a couple of points. First of all, wouldn't it be nice if all of your periodontal patients had a patch the size of their inflamed gum tissue on their forehead when they sat down in your chair? And you'd know instantly before they even opened their mouth how much inflamed. That'd be pretty cool. Unfortunately, we don't have that. You have to examine them. You have to do some things to figure that out. You can't just look. Well, the oral biome, and we'll talk a little more about this in just a moment, but it does directly affect plaque formation, arterial plaque. It directly contributes to arterial plaque inflammation and therefore heart attack and stroke risk. I mentioned that it affects the insulin system. Your diabetic patients are probably harder to control in your office because of their diabetes. And guess what? They're harder to control in the medical doctor's office because of their periodontal disease or their sleep apnea or their endodontic disease. We've got to work together. And we now know that about 15% of dementia is related to Porphyromonas gingivalis. Oh my goodness. So periodontal disease, again, I'm preaching to the experts here. But the point I want to make is that sulcus, where that biofilm is, those anaerobes love to be at the bottom of that. Those anaerobes are digesting gum tissue for their food source. In fact, P. gingivalis makes something called gingipanes, that is an enzyme that's designed to break down the surrounding environment to make their food source, their energy source. Well, and this is a biofilm that is very much synergistic. All those components are down in there. And as you well know, their toothbrush and their water pick and their floss ain't reaching this. And for those of you that aren't doing more than just routine cleanings, you might not be reaching this. Again, I'm not passing judgment on anybody. I'm just wanting you to think about your own approach. Again, the host response affects what the tissue looks like. So you can have these bacteria, these dangerous pathogens that are trashing your patient's arteries with normal appearing gum tissue. There are a couple of studies I want to share with you, and some of these are more than 10 years old, but they were really epic studies. So Dr. Pesce, in the early teens, did this study with using a cone beam, and he did a cone beam on 30 of the heart attack patients. It'd be nice if he had done it on all 101, but we know that back then it was hard to get. It's even hard to get cone beams now. But 50% of those people that had had a recent heart attack had a periapical abscess. And what I've learned from my dental colleagues is that those darn things can be asymptomatic too. So if we ain't looking, we ain't finding. Well, they also even went and looked at the clot that was in their coronary artery. And sure enough, the DNA from those pathogens, those very pathogens, was in that clot. AA and PG and even strep viridans. So yeah, and this was an association study, right? Back then it was like, okay, there's an association, but there wasn't a causation link at that point. Further, and this is a couple of years earlier, they looked at carotid artery plaque. So people that had so much plaque in their carotid arteries that they actually had to go in surgically and peel out that nasty stuff. And they looked for pathogens, and look at all of these pathogens that were in their carotid artery plaque. They didn't just transport themselves there. They came from a portal of entry, the person's mouth. And everybody had at least one, and most of them had multiple pathogens. No surprise. Again, an AA and PG in over half of these folks. Again, this was still an association study at the time. Here's another coronary endarterectomy that showed essentially the same things. And you can see they said it suggests that PD pathogens in plaque is not a coincidence, that they may contribute to the development of coronary plaque. They were exactly right. So let's fast forward to the paper I've referenced earlier, this 2017 paper. And what Bale and Donin and Vigorous published is that we know from an artery standpoint, three things have to happen to get plaque. You've got to have a certain amount of cholesterol that's going to cause problems. You've got to get it somehow underneath the endothelium. And back when they wrote this article, we thought it was that the endothelium had to be sick first, that it had to be damaged to let cholesterol through. Well, I'm going to revise that in just a minute. And then step 3 was, okay, it finally gets through. And now we start to bind that ApoB inside of the artery, and everything that I showed you in that earlier picture starts to happen. And they wrote about the specific contribution of all of these different pathogens to each of those 3 steps. And so they wrote the article saying this is a causative link. This is not just associative. And so in the paper, they showed this column B of, okay, certain periopathogens raise cholesterol levels. Who knew, right? Certain of them do increase permeability of the endothelium on top of the next thing we'll talk about. And then PG very directly helps trap cholesterol in the arterial wall. It affects that smooth muscle layer as well to make it produce the sticky stuff. What we now know in a paper that Bale and Doneen published with some other authors 3 years ago now is that oxidative stress really changes the order of this a bit, because we now know that it's the oxidative stress that gets the ball rolling. It transforms that muscle layer to make the sticky stuff, the proteoglycans trapping ApoB. That's really step one. And now we get inflammation that's damaging the endothelium. And yes, those periopathogens can also do that, but it's really not the first step. And then finally, when we have cholesterol issues, again related to the periopathogens, we've raised that. So now we have the same things causing damage, but we now understand that oxidative stress is really the prime force in all of this. And guess what? Those pathogens generate oxidative stress. Moving from periodontal disease, which has to be epidemic in your offices. It has to be. The statistics are that as we age, it's a higher and higher percentage. So whether your patient looks to have periodontal disease or not, please think about it. So endodontic disease, a finding that was surprising but is being proven out, is that one of the inflammation tests called myeloperoxidase that actually digests the endothelium. So myeloperoxidase is in white blood cells. White blood cells are in the arteries and patrolling for problems. White blood cells are inactive for the most of their life until they find an area that needs their help, like damaged endothelium. And it goes there, that white cell gets attracted there, and then it starts to release myeloperoxidase, which chemically creates bleach. And that perchloric acid that MPO creates kills endothelial cells. And one of the causes of heart attacks is plaque erosion, not full rupture of the plaque, but actually that top lining of the artery dies off, exposes the things underneath, and that triggers a clot. It turns out that both endodontic disease and sleep apnea are the most common causes of an elevated MPO level. I sent 2 patients this week to our local dental team who knows how to do all of this stuff, and they had just been in the dental office not long ago for their periodontal care. MPO came back high. I called her up right away and said, look, something else is going on. And please, let's get a CBCT on these folks. So stay tuned. I don't know what she's found because this just happened this week. But this myeloperoxidase is absolutely predictive of plaque rupture. When it's high, the 10-year risk of plaque rupture is exponentially higher than if it's not elevated. Half of heart attack patients, I told you already on the PESI study, had a periapical abscess. We're finding them all the time. And myeloperoxidase is known to elevate with infections. So there's the link between the endodontic disease and MPO. Kentucky Dental School is actually starting a trial to see about this, and hopefully we'll get some published data on that soon. I mentioned earlier that PG absolutely plays a causal role in Alzheimer's disease. I'm not going to present all of that tonight. I just wanted to make that as a statement. But that article, which in my humble opinion may win a Nobel Prize, was published back in 2019. Sleep apnea. Again, many dental offices are already looking for this. It's way underdiagnosed. I promise you it's underdiagnosed, just like periodontal disease. In Renew Health, 100% of our patients get oral saliva bacterial testing, get a home sleep study, 100%. And guess what? 80% of our folks have sleep apnea of one degree or another. 80%. We're not cherry picking those folks. We're doing everybody that comes through our doors. Well, sleep apnea does much more than what's on this slide, but I want to make the point that oxidative stress is generated by these arousals and interruptions and oxygen level drops and blood pressure spikes and all sorts of things. And the more the oxygen drops, the more damage and oxidative stress there is. And so they're developing plaque because of their sleep apnea. Sadly, in the medical world, so many things, the diagnostic criteria require it to be, in our eyes, severe. So sleep apnea is severe, and CPAP is covered by the Medicare industry if there's apnea-hypopnea index is above 30. Well, we know if it's above 5, it's creating oxidative stress. Why would I leave that behind? So again, just like thinking about periodontal pathogens and silent periapical abscesses, think about sleep apnea in your folks. And part of what happens is the fight or flight center in the brain is impacted. And so stress hormones are released. That affects blood pressure and insulin resistance. And it's why they have even higher blood pressure when they're sound asleep. They are ripe for arterial disease. And remember, oxidative stress, independent of the arteries, is damaging brain cells and heart cells. So that's the reason there's an increased risk of dementia. Not to mention that this is going to aggravate their oral biome. And those of you that are already doing salivary testing, you can recognize in an instant the patterns that are associated with different pathogen profiles. So it absolutely is a circular loop to some of the other oral health issues. So as a medical doctor, what I would love for my dental colleagues to do for our patients is be objective with their periodontal disease and salivary testing and selectively doing cone beam. I'm not going to say, I didn't mean to say that everybody needs a cone beam. That's not true. But certainly if they've already had dental root infections, they might have them elsewhere. And if they've got a high MPO level, like I mentioned for 2 patients this week, think about airway screening in these folks. And then really define your goals of therapy that should include halting and stabilizing and reversing the inflammation you're seeing in their mouth, because that's going to help reverse it in their arteries. I made up this mnemonic several years ago to help non-physicians. I think about who should I test? Who should I be worried about? Well, you're taking family history. So if they've got a family history of cardiovascular disease, that's a check. If they've already had a heart attack or a mini stroke or a stent or bypass surgery, they have arterial disease. If their apple-shaped waist is bigger than their hips, so that apple waistline is the dangerous visceral fat, they've got oxidative stress. If they're on treatment for their blood sugar or their cholesterol or their blood pressure, they are arterial disease patients waiting to happen that may need a dental solution. Certainly if they have any complaints with their teeth, automatically, oh yeah, do your gums bleed when you brush? Yes, Laura, they do. Okay, that's a problem. That's not normal. Let's figure it out. And then smoking clearly and tobacco of any sort. And we now know that nicotine of any sort, vaped, gums, patches, all of those, nicotine is a direct oxidative stress creator. So they don't get a free pass just because they're not inhaling their tobacco. So I'm going to pass it off to Patti and I'll stop sharing, but that's our website if you want to learn more about us. And we would love to know who's willing to see some of our patients. We are a national telemedicine company. We have patients in not all 50 states yet, but we're rapidly growing. And Patty's going to talk to you about this idea of even scheduling in your office this very simple artery test called a CIMT to define folks that have arterial disease for you to help manage and for you to find a dental provider to help. So I will stop sharing so Patti can take it away.
Okay. I'm gonna go way down. I don't want to make anybody dizzy, but let me get down here.
And I don't, yeah, and you're not on the screen yet with the slides, Patti.
I'm not. Okay.
Oh, I can see him.
Okay.
I'm making you dizzy. Sorry. I didn't think about needing to be advanced here.
Scroll on the side. Well, I think this is so important when you get to the screen. I think this is, Dr. Wilkerson, we talk about all the time. People constantly reach out to us. Where's the dentist in Georgia? Where's somewhere I can send? And Dr. Wright, you're part of that call. I get Patti calling me saying, who do you have in Nebraska? Right? We know this is one of the greatest pain points because, right, we've all done it working on the medical side, trying to help you as physicians, right, get our dental patient too. And we say dental patient, our medical dental patient to, clinicians in the right hands who at least understand these concepts. I always say, nobody's asking you to be perfect. We're not perfect. We're dealing with humans, but there is a whole nother level there that we have clinicians where we'll send a patient and they're like, you look fine. They're crazy over there, right, Patti? Right, Dr. Wright? Like, I don't know what you want me to do here. So I think this is just so fitting where we're going. And Patti, I know you're going to take it away from here because that's what really this whole medical dental collaboration is about, is kind of closing that gaps that we can all work together. And there's really no better community. I'm going to give our community here, IDM, just a shout out to all of you. I'm so grateful you're all here because really this is one of the stepping stones. We've been bringing collaboration, but this is more and more of what we want to do. And Dr. Wilkerson's going to talk about that end, but Patti, kick us off. Let's talk about true collaboration. What does that look like?
Yeah. Yeah. So what is medical dental collaboration? The World Health Organization defines it as a key strategy to improve health systems, improve patient outcomes, and improve workforce effectiveness. And what it means is that a collaborative practice happens when multiple health workers from different health backgrounds work together with patients, families, caretakers, and communities to provide better care. I just heard Dr. Casey Means on a podcast talking about the really big problem with our healthcare today is silo practicing. She was talking about so many patients have like at least 8 doctors or whoever healthcare providers on their team, and they're not talking to each other. So there's no way we're going to get optimal outcomes when nobody's talking to each other. So what's our why? Why would we want to collaborate? Well, number one, we practice to some codes of ethics, whether it's from the Declaration of Geneva, the American Dental Association, the American Hygienist Association. We're expected to work together as healthcare providers, to consult when we need to with other providers, refer when we need to, and put the patient's welfare first. So medical dental collaboration has been a dream for a lot of us for a long time, and it's been a struggle. I thought that in 2011 it was going to actually start to happen. We went to the first American Academy for Oral Systemic big seminar, and it was wonderful. And we heard Dr. Bale and Dr. Duneen, and Dr. Bale even, speaking to a huge bunch of dental providers, said, "We need your help. We guarantee our work, and we cannot guarantee it without the patient having a healthy mouth. So we need your help." So for several years, just trying to help doctors that I was working with in their dental practices to make a relationship, collaborative relationship with some local functional physicians, sleep doctors, whatever. It's hard. It's really hard to do. Nobody's got time for it. And so we don't collaborate like we should. But in 2017, I was lucky enough to be founding member of the Heart Attack and Stroke Prevention Center of Central Ohio. And during that practice for about 7 years, we did create some really good working relationships. The easiest one was that we got our dentist and our cardiologist married. That was easy, but it doesn't always happen that easy. But we practiced in the Heart Attack Center for about 7 years, and then Dr. Goulder and I just joined Renew Health in 25. So now my dream of medical dental collaboration has become my job. So, who is Renew Health? We've talked about Renew Health a little bit, and this talk is not about Renew Health. It's about you, how much we need you to help us, and our patients. So, Renew Health has 4 levels of care. We are a nationwide telemedicine model, like David said. We deliver preventive cardiovascular care grounded in the Bell-Dunning method. The Bell-Dunning method is a peer-reviewed, evidence-based approach focused on early detection and management of arterial disease. They start out with the CIMT, early detection. It is proven over the last 25 years to work, and they do guarantee their work. If you, heaven forbid, have a heart attack, stroke, or develop dementia under their care, they give you your money back. Renew honors that guarantee as well. So our process is our patients come from everywhere. Like David said, I don't know if we have a patient from every state right now, but we have them all over the country. And they come because they are afraid of having a heart attack or a stroke like a family member did. Maybe a lot of guys will tell us, well, I'm 66 years old and that my dad had his first heart attack then, or he passed away then. They're either that or they're afraid of having their own second event. They're all looking for a CIMT. The CIMT is quite the buzzword out there. I don't know if you guys are hearing that out there from Dr. Ford Brewer. I say Dr. Brewer has saved more lives than anybody, but he is really getting that CIMT thing out there. And that's where a lot of our patients come from. They're looking for a CIMT. And, or maybe they've had recent labs that weren't optimal and they're worried about themselves and they know they need more help than just what the standard of care offers. So one of our most popular levels of care, we have 4 levels of care, and the most popular one we call the full arterial reversal. And what's included in that is genetic testing, yearly CIMT, saliva, and sleep testing. We do the root cause workup like David was talking about to find out what's driving the inflammation or the oxidative stress. We do tune-up labs 4 times a year, and then they get a consultation with the physician to go over those labs and come up with a strategy for the next quarter, what they need to work on. And we have 24/7 people answering emails and making sure that nobody gets dropped. And so we have a lot of care coordination going on. We have dental, dietary, and movement coaching. We've just now added movement coaching. So I think that's going to be a really big part of our plan as well. And then, of course, if the patient needs prescriptions, we do manage those. We hope our goal is for you not to be on a prescription, but if you need a drug, you need a drug, and we do that until we can get you off of them. So, and then the supplements we manage the supplements as well in that plan. So when we do the root cause, when we're trying to find all the root causes and we come up with the 3 that originate in the mouth, then that's when I come in. Doctors, when our patients have high risk of arterial disease, of having an event, they have high risk pathogens, they have elevated fire alarms, inflammatory markers, possible endodontic infection, and mild to moderate sleep apnea, then that's in the dental arena. That's you guys. So when I get that referral, my process is that I email the patient. The doctors email me, then I email the patient and ask them out of professional courtesy, I want them to check with their dental provider, their current dental provider, and ask 3 questions. And when they get the answer to those questions, then I want them to set up a Zoom call with me. So the 3 questions are, do you utilize salivary testing for diagnosis, treatment, and management of periodontal disease? Can you provide a CBCT scan read by a dental radiologist? And do you have a protocol in place for mild to moderate sleep apnea? Then I have a consultation with the patient and we review the oral health connection of the root causes with their personal tests. I get on a Zoom call and I bring up their CIMT, their saliva test, any kind of medical labs that if they're like diabetic or insulin resistant, we need to talk about that, how that's connected to their dental health. Any fire alarms that are elevated, like David was talking about the MPO, and any genetic connection that we need to talk about. Maybe they need to be, maybe they need to use certain products. So based on their genetics. And then we look at their sleep study and make sure that, they understand that dentists do have sleep programs and we would want them to help us with mild to moderate sleep apnea. Could be that they can use an oral appliance for that. Then my assistant, the AI person, is making notes for me. And so I send the patient after the call, the notes from the call, links to home care products that they always want to know what they can start doing today different. So I give them some really good products to use. And then I send them a form that we can request dental records from the dentist that they wind up seeing. And then if their current provider can provide those services, which is very seldom that they can, I will go ahead and send a referral email from the doctors to that dentist. If not, then I have to find a dentist somewhere that can help them with those 3 things. So that's when the struggle begins, and that's when I'm so happy to have all of you guys, the IDM Scholar Society, our AOSH members, our Baildonin community, all the saliva testing companies to really go there and look for their provider directory and find someone. And then I have to talk to that dentist to make sure that they're on the same page with us. All of our communities are not on exactly the same page. So when we send our medically compromised patient, we want to make sure that we are on the same page and looking for the same goals. And then I send the patient that contact, and then they tell me if that's someone that's close enough to them or they think that that'll work out for them. And so then I send a referral email basically to introduce Renew Health to the doctor that we're referring to. I copy the patient on there so they know what's going on. And I explain the chief concern, whatever the doctors are mostly concerned about. And then we do send all the medical records and even the last medical notes, the saliva test, the sleep test, and the CIMT. And now when we were working with Dr. Goulder in the Heart Attack and Stroke Prevention Center, it took us a while to figure out, okay, how do we let the dental team know what the medical team is doing or what Dr. Goulder was doing? And so I finally came up with a system that we're going to share everything so that you know the rest of the story when you get them as a dental patient, as a medically compromised dental patient. And then I put together a little fillable form because I want the dentist to share what they have done, the dental records. And so I gave them a little fillable form. They can upload x-rays, perio charts, things like that, and give me a little statement just about, what they've done, how they did it, and what they feel the status of the patient is. It's very easy to understand for our medical doctors because they're not dentists. They don't understand the jive sometimes. So this form has worked out really well for us. And then I just want to tell you, David shared one story. It seems like MPO, we've had a real rash of elevated MPO lately. And we had this patient, I'm going to call him patient, and he did have high risk as far as his CIMT was concerned. His saliva test was moderate. He had mild sleep apnea, and he had a history of root canals. So David had asked him to talk to his dentist to see if he could get a special x-ray to confirm that he did not have an infected tooth. And 3 months later, he came back, still MPO was still elevated, and he hadn't really talked to his dentist. So I gave him a call, and when he answered, he was in the car with his dentist, who happened to be his wife, who is a prosthodontist. And so she let me know that he did not have periodontal disease, he did not have sleep apnea, and there's no way that that would have been pertaining, elevating his MPO. So I said, okay. So we had a lot of going back and forth, a lot of emails. She said, okay, I'm going to do this, I'm going to do that. And so what she did find with the CBCT, for one thing, was that he did have 2 infected teeth, and she was shocked. So we had a lot of emails going back and forth, but this one was just so classic. She was like, thank you for reaching out. I filled out your form. Let me know if it's sufficient. So that's wonderful. I love it when they actually will share with us. And she said, I did about 15 of my patients have a CBCT, and they had old root canals, and all of them had infection. I could not believe it. Most of them have health issues, arthritis, bladder infection, dementia, cancer, etc. And I couldn't tell them what to do next to help them further beyond dental. So I was going to reach out to your team for the next steps. I would love to explore our partnership options so that we could help more patients. That's what I call beautiful medical dental collaboration. That's what we're all wanting to be able to do, which is what I want to do with you guys. So I want you to ask yourself if you're ready for a call from Renew Health. I want you to critique your periodontal protocol, because it's going to be about saliva testing. I want you to be objectively and subjectively diagnosing. I want you to really define your dental treatment and your periodontal therapy so you can share it with me. And I want you to know the percentage of reduction you're getting with your protocol. Is it working? And then I want you to be able to take a CBCT, or if you don't have the machine, I understand it's very expensive. I think it does pay for itself. But if you don't have that, at least refer out for it, especially if the patient has a history of root canals. We found a lot of young men who play basketball, and their front tooth, they have an abscess and they didn't even know it. It's asymptomatic. So a CBCT is definitely in order for, I say, most patients, to determine if they have that infection that's going to drive that heart attack. And then if you don't have a protocol in place to help patients with sleep apnea, then put one together or collaborate with a sleep specialist in your community or Renew Health. So what you can do is you can be ready to halt, stabilize, and reverse inflammation with us. So one of the first steps that, a lot of our dental partners are like, well, how do we work together? What else can we do? And the thing that you can do, we've talked about how valuable the CIMT is, and you can actually go to their website. We use Cardio Risk Labs. You can go there and find they're having events all over the country. Unfortunately, there are more people wanting the CIMT than there are events going on. So that's why we encourage you to do a CIMT day in your practice. It's not a huge moneymaker for you, but it doesn't cost you. And the nicest thing about it is that Cardio Risk will just send a sonographer right to your practice. You don't need to do anything. And then Renew Health is going to help you promote that day. You only need 15 patients. So by the time you do a CIMT for yourself, your family, your patients, your community, that's going to be more than 15 patients. And I was just thinking about, what is the value of those CIMT days to the practice? And so I reached out to one of our very respected, valued dental partners, Dr. Maria Miller-Maraldi, and at Root Cause Integrative Dental Medicine. And this was her quote, and I just want to read it. She said, "I want to provide more reliable heart health information measuring soft plaque than standard of care test provides. I am a Beldonine ambassador, and I want to make it easier for my patients and others in the community to start learning about their heart health and risk. Most patients don't know about this imaging and how valuable it is, and hopefully will learn about the Beldonine method along the way and start reversing heart disease. We want to show our patients that we're not only invested in their oral health, but their systemic health as well. So I appreciate Dr. Rinaldi sharing that with us. So I say medical dental collaboration is a reality. And what we know is on a good day, we save a smile, and on a great day, we could save a life together. So, like David said earlier, we would love for you guys to work with us. Let me know if you're ready to collaborate. I want to know where you are. We need you. And so I want to hear from you.
Wow,
Okay.
Patti, thank you. And David, oh my gosh. I
Thank you.
have to say, I had to write down the three things because I love that you're kind of throwing the ball back to us of just us doing some internal reflection. I think all of us asking just, are we really ready for that phone call? I think that's great because I'm always picking up the phone, making the phone call. So I love to be able to do that. And Dr. Wilkerson, you're going to walk us through some of those next steps, but I have to say, critical, right? Let's critique our own periodontal therapy. Are we saliva testing? Are we taking the CBCT? And are we screening airway? And those are really three things that everything that we're trying to teach here and really work towards. And in fact, Dr. Wilkerson is going to share a little piece. We want you to go ahead and drop questions as Dr. Wilkerson is going to go through our exciting news of certifying practices so that Dr. Wright and Patti can come on here and say, okay, who is where? And we can go find them and they don't have to worry about picking up the phone.
Yeah,
Would that be helpful?
Yes.
absolutely. Yeah. All right. So let me see if I can share now. Thank you guys. That was so well presented and so helpful. Um, there we go. Okay. So I'm going to share now, and hopefully you can see my screen. It just is black right now. Um, I want to kind of share with everybody a little update on what we've been learning and where that's taken us, exactly what Patti and David have been talking about, but a new twist. You know, many of us on this call in the study club are very focused on the science and the research and the data and the problems that we see and the comorbidities and all these tremendous needs that we have all around us throughout our communities and across the country. But one of the things we have to ask ourselves is what we're interested in, what our patients are asking for, and how can we better, approach the public in order to pique their interest in pursuing the things that we know now are available to begin breaking down these problems and putting health back together. And so, as you may be aware, there's a tremendous growth in what's being called the health and wellness movement. And Amy LaRocca, who is a fashion journalist, was interviewed last year by the Aspen Institute, and I want you to hear what she said, and this is going to kind of jump this conversation for us. So listen to Amy.
So I started getting more and more and more interested in this idea of wellness, and it got bigger and bigger and bigger. And I started out dipping my toe in with a cover story for New York Magazine, and then I was like, oh, this is way bigger than that. And that's how I got interested in it. I realized that wellness was the new luxury good that everyone wanted.
Isn't that interesting? Wellness is the new luxury good that everyone wanted. And she began to talk about how some celebrities, even out in Hollywood and California, instead of talking about their clothing now, are talking about what they ate for breakfast and what their workout routine is. And that's becoming in vogue now as really a type of fashion. And so when we talk about wellness being the luxury good that everyone wants, what exactly does that mean? And so here was a survey that was recently done, asking people to prioritize what wellness attributes that they are considering their highest priorities. And look at some of these: better health, better sleep, better nutrition, better mindfulness, better fitness, and better appearance. And as I was looking at that list and Laura and I were talking about it, we realized there really wasn't anything on that list that couldn't be related to services that we could provide through dentistry. And so we've kind of shifted our emphasis now toward a model that's about health and wellness and what we're going to talk to our patients about. Look at this: the global wellness economy market size and projections, and it's exponentially growing. And by the year 2029 is projected to be an industry where $9.75 trillion a year is being spent by the public worldwide. That's the largest single market size of any industry in the world. And we live right in the middle of it. That is, the health and wellness movement is something that we in dentistry live right in the middle of. The question is, do we even know it? And if we do know it, what are we doing to promote this, and what we're doing together with the Dr. Wrights of the world to promote health and wellness in exactly the direction that people want, whether they can quite fully describe it or not. And so Laura and I have kind of rewritten our vision and mission for IDM, and we're thinking more along this line, that our vision is we will, together, all of us, lead the movement that shifts dentistry toward a health and wellness centered model. And our mission then would be to create, educate, and train health and wellness centered protocols that every dental practice can implement and can work with Dr. Wright and other practices and groups like his to collaborate on the things that we can offer and provide. And so our curriculum at IDM has been kind of retailored, and it's centered on building a health and wellness centered dental practice with introductory level, then foundation level seminar, advanced level individual courses on these different subjects, and then finally a workshop that is about what we're calling the 3 S's, that is sleep, saliva, and sugar solutions. So I wanted to share with you just for a moment about that, because that's coming up, and it really could provide a way for all of us that are engaged in this conversation tonight to get together almost in a reunion setting, but in a setting of an update of what is the latest information that we can glean and implement in our practices on Monday morning. What are the new biohacks? What's going on with AI right now that we can begin to implement? And so we're going to have a workshop, a live workshop here in St. Pete, June 26th and 7th, that we want to invite you particularly to come to. We're going to limit it to 40 people, but we really would like to get together with our group, with the ones that we are learning together with month by month. Let me tell you a little bit about that workshop, because as we focus on really what Dr. Wright and Patti have been talking about, which essentially is sleep, saliva, and sugar solutions, we're going to talk about allergies and sleep apnea and upper airway resistance syndrome. We're going to talk about apps like the SnoreLab app. We're going to talk about things like high resolution pulse oximetry screening that every dental office can do tonight, and get very important information back that can guide our treatment or referrals. And then other apps and hacks like mouth taping and oral appliances. So we're going to focus on using high resolution pulse oximetry. And actually our goal is that most of the people that are involved with the workshop will actually take it home, that is to the hotel, on the first night of the course and use it for themselves. And then we'll look at the results the next day and talk about it together. Then when we talk about saliva and salivary testing, which of course worldwide. Laura's known as the saliva hacker and truly is the world's expert on this. She's now reviewed over 100,000 salivary tests. I don't think anybody else has looked at more than maybe 1,000. So, and helped develop the protocol. So we're going to look at bacterial results, viral, fungal, interpretation, protocols, post-testing, and implant success, or that is, perhaps I should say, implant failure as a result of the fact that we're not really studying these pathogens before we take teeth out and pop implants in and expect everything to be just fine. So we're going to decode your saliva at the course, and we'll do salivary testing on every participant. And then when it comes to blood sugar, insulin resistance, something that we know there's a relationship that's bidirectional between diabetes and blood sugar and periodontal disease, and yet almost no dental offices worldwide do anything to evaluate blood sugar, to address nutrition. And so we're going to talk about the latest and greatest, which is being really promoted very broadly by the top integrative physicians, and that is using sugar biosensors, the continuous glucose monitor. We have developed a relationship with Dexcom, and Laura and I were at the Rocky Mountain Dental Congress in January, and we were able to place 400 sensors on participants in the presentation that we gave on one of those days at that meeting, and really generated a lot of excitement. Well, Dexcom has agreed to provide for us biosensors for all the courses that we teach, and so we're going to place continuous glucose monitors on every participant. The whole idea is we want to build protocols from your own personal experience in the workshop that you can bring back to your office. And this has really caused us to think and talk about a lot of things that we're seeing that you see and you understand too. And that is that scientifically, most dental practices, and I would say medical practices too, are really broken. And when I say broken, I mean because we see SRP failures that are typical after only 12 to 24 months. There's a reason for that, but most practices don't know why, and we do. Um, Perio is seen as an incurable disease, and how interesting it is that we say cancer isn't incurable, but perio is. And I know Dr. Tom Neighbor, who's on this call, is one who's really promoted the fact that periodontal disease is curable. And it's something that we should be looking at as that possibility is there. And this is not a lifetime curse that our patients have. Inflammation and bone loss is a vitamin F, meaning flossing deficiency, is how most practices look at this. And so how false is that? Periimplantitis is a confusing mystery, and yet we know that it's a oral pathogen driven disease of implants that can be evaluated, that can be measured. And so that is a broken part of the system of most practices. We also know that dental medicine is rapidly evolving. Practices are falling behind. And so to most practices, we could say, you've never seen your patient's real data. That's the problem. And wouldn't it be better to lead your patients where you've gone yourself? And so we want to start that process where we're learning how to do that personally, and then we can take that excitement, take that data, take that testing and information back to our practices and begin to change our communities. Most dental teams are missing the most important data. We've been trained to look at what? Tissue. We've been trained to look at bone. We've been trained to look at radiographs. But yet, as David and Patti have pointed out to us tonight, disease starts long before what you can see, yet not before you can begin to evaluate and measure. Patients today aren't just asking about their teeth anymore. They're asking questions about things like, why they're inflamed and why they're exhausted and why their health isn't improving, no matter what they might be trying. And these are answers that they're looking for. And they will gladly receive those answers from us in our dental practices. And as we collaborate with the Renew Healths that are out there, the first immersive experience where you become your own case study could be in this workshop. Stop guessing. See what your patients show, that is their signs, and feel, that is their symptoms. Let's see what those things are. What percentage do you think of the disease story are we missing? Well, we'll find out, because are our patients having sleep crashes and hidden pathogens and glucose spikes? If so, we can find those things because they can't hide from us anymore if we do proper evaluation using proper protocols that we can build, even beginning with our own real data. And so our goal, all of us together, is to become leaders in what we might now call precision dentistry or precision oral medicine, that goes along with precision general medicine that Dr. Wright is doing in his practice. And so as we begin to get specific, we can see that there's three hidden drivers that are destroying our perio results. Number one, poor sleep, because poor sleep leads to oxygen desaturation. That leads to oxygen desaturation in the mouth, that leads to oral anaerobic pathogens really beginning to proliferate. Infected saliva is a term I think we should be using, where we see oral pathogen dominance, and yet are we even measuring that? And we can. Increased blood sugar causes inflammation spikes periodontally, we might say, and therefore we begin to see this advanced degree of chronic inflammation despite all attempts to do intraoral therapy. And so are we looking at both sides of that equation and analyzing and studying it and addressing it? That's our concern. And so what we want to do is learn to diagnose what others are missing, be able to explain inflammation through test results, that is data, to patients, diagnose, diagnose, diagnose. With that, we'll see increased case acceptance dramatically, which many of us have seen, as well as adding new revenue streams immediately. And so with that, this workshop doesn't just teach you dentistry, but it transforms how you think as we really dig in deeply together and immerse ourselves, learning how to be, instead of reactive, predictive, and learning how to be, instead of symptom-based, root cause driven in our work, and learning to move from guessing and hoping to data guided precision. So all of this is available to us. We're so excited, and we're seeing this happening in individual offices, but we really want to start putting it together as a team. And so what we're going to do is move this workshop kind of to the top of our curriculum. And then for those of you that work with us on this, we want to take you through our curriculum. As we do that, we want to begin to create a program that is a scholar program. We will give you homework. There are certain things that you would need to do in the way of salivary pre-testing and post-testing, where you're able to clear these pathogens. We want you to be doing home sleep testing in a way in which you can begin to analyze and show the results and what can be done, even some dental solutions and a number of things that when you complete this program, then if you graduate from that, we're going to put you into an IDM referral network, that we want to have referral sources that are in every state around the country, so that when Patti and David call us and say, hey, I need somebody in Colorado, I need somebody in Texas, I need somebody in Massachusetts, I need somebody in California, we're going to be able to give them that resource. In fact, it will be on our website and available to the public to go to practices that are set up and ready to go, which honestly we have not been able to do so far. because we have referred people that have been to some of our courses, and the patients are calling us and saying, well, they say they really don't do salivary testing. Well, they say they really don't do any analysis of sleep. Well, they're really not familiar with how to analyze blood sugar, and they're not using continuous glucose monitor. And so they weren't really able to help me. And there is such a shortage right now for us to have qualified clinicians that we have faith in, that we have been able to test and see that they're capable and qualified so that we can pin them on our map and begin to promote their practices as referral sources. That's what we want to do. So we want to invite you to come be with us in St.
Huh?
Petersburg for this
No,
workshop.
almost.
Laura, are you talking? No. Okay. Um, we want to invite you to come. And of course, if you'll use the study club code, we'll give you a 10% discount. And we really have discounted this dramatically already. Dennis, I would tell you the cost of this workshop for you will be less than what you're charging for a crown. And for your team members, your hygienists, it'll be half of that. And so another thing about this date is, remember, we're in St. Petersburg, and we're 15 minutes from one of the top beaches in all of the United States, and we're 90 minutes from the top 5 destination attractions in the world. And so, how about you bring your family and make this a summer vacation outing, spend 2 days with us, and then go enjoy the beach, go to Disney, and uh, all the different attractions that are nearby, and let's have a great time together. So, Laura, why don't you chime in?
Yeah, I just want to welcome everyone to our workshop. I think so many people ask us, how do they start collaborating? And I just want to say, this is it. This is how you've gotten 2 ways that you can get started. You have a direct path to Renew Health. You've had other direct paths, but this is actually to be certified. And I think this is something so many of us need in this community to even help each other. So that's the other thing, is you're surrounded by the people who want to be a part of that. And I think networking with those same individuals is very important. I do, though, want to see, I'm not seeing any diehard questions, though, here for Renew Health. I see people who want to collaborate, Dr. Wright, but I'm going to just kind of pause questions, drop them in the chat here while we do have both of them still available, hanging on. But any questions for any of us, please ask. We want to make this easy. We want to make it understandable. And I think that's the other thing that you're sharing, Dr. Wilkerson, is that we want to actually get certified clinicians or certified practices. That is what the biggest pain point. I'm just going to share, because I do work with the Urban Monk on the GI side, and we have that same pain point. I'll say the same thing when I worked with Dr. Gina Pritchard. That was our biggest pain point. And I'm sure, Dr. Wright, you could chime in, is that you're paying for a hygienist to be on your team, and yet we struggle, right? We're struggling to actually collaborate. And I know sometimes the dental community has a hard time hearing that, because they think they're looking for your side, but it's a real struggle to find somebody to acknowledge what I want to say, the cutting edge research and knowledge with implementation. Patti was sharing about the root canals. That story goes back. Patti and I always share just about scaling and root planing. I'll tell you, I was just on with a patient yesterday, and as we were talking to the dentist, the first thing he said to me is, "Oh, the patient's healthy, no issues." Then we start asking, has there been a history? Great. Then I guess they just need a prophy. Can we make sure we're doing some airflow or laser and really get in there? And he's like, "Oh, well, she does have some 4 or 5 millimeter pockets." And so it's like we're not communicating, right? That's how I feel. It's like we're not speaking apples to apples here. We think we are, and then all of a sudden, you take a deep breath back, and you're like, okay, how do I start over? So I think it's just really important that if anybody has questions, we're gonna drop those links. They're all in there. But to make collaboration even easy for your team with Patti, I think that's the other thing is, hey, what do we need to have in our practice? And then vice versa. I always want to tell hygienists, Dr. Wright, that they don't have to know all the inflammatory markers. They don't have to know medicine. They have to know their part. How do you feel about that? That's what I always want to say. Don't be afraid. I think there's some fear there.
Absolutely. And again, we're all learning, and the science is always changing, and every patient is unique. And I mean, this has been a fantastic meeting, this last part, to listen to Whit and Laura. What you all are doing is phenomenal. And in the medical world, we do have the same challenge of quality control, is the word I'll use. You know, you can know the science, but if you're not doing it, if you're not implementing it, if you're implementing it haphazardly, you're just wasting your time and theirs.
Right.
Well, I do get a lot of people who say they do all those things. They say yes to all three things, but they do them in a real different way. And they're not successful sometimes. And so I was saying earlier, we need partners who are on the same page. So this is wonderful, that we've all been studying together. We have this opportunity to continue to study together so that we can really depend on each other and know that our patients are going to get the best care.
Yeah, I think that's what's so valuable. And knowing that you're there, Patti, I always say, Dr. Wright, to anyone that's, hey, there's a hygienist there. She is your colleague. She is your friend. She's going to speak your language and help you too. And I think that's the other thing as a dental colleague to dental colleague, I just admire that you do have Patti there. I think that is crucial to kind of help through the steps as we work together. So I think that is so valuable, and I hope more and more of your medical providers out there, if you're on here, hear that. But you are in just about every 50 states, correct? Correct me if I'm wrong. I think that's important too, right? That is one of the big messages. I think that people want to even refer to you. You guys aren't even asking that, which I think is unique tonight. They aren't asking you to send them patients. They are saying, hey, we want to send you patients. So I hope my dental colleagues are hearing that. That's why they're here. They're saying we're looking for you. And I think that is a very important piece of this puzzle.
Yep, that was my point. This is not about Renew Health. This is about our patients who need you.
Yeah, that's right.
So somebody did ask in here, can Dr. Wright repeat the statistics on endo abscesses and heart attack?
Yeah.
There's a two-part question here, and then is PG directly linked to Alzheimer's? And was that a 15% increase? But let's start with the first one. What was the statistics on the endo abscesses?
So they took 101 folks that had an acute heart attack. 30 of those did a CBCT, and 50% of those 30 had an abscess.
Right.
So they didn't do all 101. Not everybody agreed to get a CBCT, but 50%. I can tell you that Brad Vale and Amy Doneen talk about a couple of patients they had before we understood this connection. And Brad tells the story of one of his patients that had an acute MI. He went by the hospital to say, golly, first of all, how are you doing? And I don't know what we missed. Because, Brad authored the method, he and Amy. And the story goes that the guy said, well, I'm doing everything. But he said, Dr. Bale, I've got this tooth that's been bothering me. And Brad just lit up and said, tell me more. And that patient had an abscess. And that was one of the early clinical observations that led to this. And that's where we all can advance the sciences with your clinical observations.
Totally.
Something that Renew Health is doing and will continue to do is publish our findings and publish our outcomes so that we can all learn together. In terms of PG and Alzheimer's, so it is causative, and 15% of Alzheimer's cases are caused from PG. So we don't really have a what percent of PG folks get Alzheimer's. That study hasn't been done, but you can imagine it must be a significant percent because PG is one of the last ones that gets populated in the mouth. And yet it's still having a huge impact on Alzheimer's. So we don't have the reverse study, but yes, 15% of Alzheimer's cases are related to that. Great question.
Well, we need to build this community out, and that's what we are all about together. And everyone on this call is a leader uh, because your interest is continuing to grow, and there's so little application that has been done and implementation that we've just got to push that now because the information's all available. And for really getting started in a great way. So it's 9:31. I think we promised we would wrap it up so some of you can have dinner or go to bed or go home. And so, David and Patti, we can't thank you enough. It's been great connecting with you all and introducing you to our community. And it's just been an honor. And we are so impressed with the work that you're doing because you're one in a million. And we, certainly understand that. And so thank you for sharing your knowledge with us tonight and motivating us, to really do bigger and better things like you've done. And so thank you. Thank you, Laura.
I will be looking for you guys.
Yeah, betcha. Well, you're stuck with us for life. You know that. Yeah.
I like that.
All right. Well, then we'll sign off for now and just thank everybody for being with us. And we'll look forward to seeing you hopefully in June and then many times after that. So, and I guess we have a study club meeting in
Beginning in June.
June. Yeah. Okay. So we'll see you before that date. Okay. Everybody have a good rest of your evening. Bye.
Good night. Bye, everybody.
Bye.